Most of us don't really remember reading the Women's Health Initiative when it first came out, but we might remember hearing about the WHI. What we heard was pretty simple. Hormones are dangerous, or maybe hormones cause breast cancer. The more time I've spent actually going back through the history of the WHI, not just the data, but how that data was released, the more I've realized something that's really important. The WHI didn't just publish results, it created a narrative. And once that story took hold, it became pretty hard to change. You can't really put the hormone genie back in the bottle. Today, I want to walk through what actually happened, not in a technical or academic way, but as a sequence of events. Because when you look at it that way, you start to understand why this one study still casts a pretty long shadow over hormone replacement therapy to this day. To be fair, the Women's Health Initiative was a massive undertaking. It was well funded, it was well intentioned, and used some serious scientific methods. But it studied something very specific. One hormone regimen, conjugated equine estrogens combined with medroxyprogesterone acetate. Those hormones were used in women who were, on average, in their early 60s. Many of those women were more than a decade past menopause. The goal wasn't symptom relief. In fact, having hot flashes was cause for being disqualified from the study. The purpose of the study was to decide if replacing hormones could prevent heart disease in postmenopausal women. Unfortunately, the women starting hormone therapy today don't really look like that population that was in the study, over 60 with little to no menopause symptoms. So right from the start, this was a study of a specific formulation in a specific population for a specific purpose. And that distinction is important, but as you'll see later, it didn't actually survive what came next. In 2002, the estrogen-progestin arm of the WHI was stopped early. And that phrase alone, stopped early, immediately created a sense of alarm. But the reason the trial was discontinued is kind of important. The study crossed a pre-specified statistical boundary for breast cancer. And when that finding was combined with a composite outcome that the WHI called a global index, the overall balance of risks versus benefits tipped a little bit toward the negative. So the key point is that crossing a statistical boundary doesn't mean that a therapy is suddenly dangerous. It means a monitoring rule was triggered. That's an important distinction, and it was one that sort of got lost almost immediately. This wasn't an emergency shutdown. It wasn't like a 5-alarm fire or anything like that. It was a statistical tripwire doing exactly what it was designed to do. But that sort of nuance never really made it into the public conversation. Patients do need to understand some of the nuances around hormones and menopause, but bringing in that nuance to patients takes some time. It's not always realistic or even practical to try to cover every nuance of hormones and menopause during an office visit. The real story is maybe long, it can be complicated rather than simple, and for many patients it quickly turns into information overload. Maybe they get kind of glazed over. Well, you've probably experienced the situation where you try to reassure a patient, you try to explain the Women's Health Initiative, you try to address their concerns, and before you know it, half of your visit is gone, just undoing the headlines from 20 years ago. And that's exactly why I built a patient education tool called Simple Hormones. It's specifically designed for this particular problem that a lot of providers have told me about. It walks patients through the WHI in plain, simple language, no medical jargon, language that anybody can understand. Simple Hormones answers the most common questions that patients have. It addresses their fears and their hesitations with empathy and evidence, so you don't have to. And most importantly, it lets patients absorb that information on their time, not yours, so they come back to the office informed and ready for a real conversation. If you want to learn more about Simple Hormones, visit simplehormones.com/simplify to see how Simple Hormones helps you simplify your hormone practice, saving you time and frustration. With that in mind, let's go back to July 9th of 2002, because this is where the nuance didn't just get lost, it got trampled on. Before most clinicians had a chance to read the data, the NIH held a major press conference. A press release went out that's shown on the screen, and then the headlines spread globally pretty fast. And that's where things start to get a little uncomfortable. According to accounts later summarized by Dr. Avram Blooming in Chapter 1 of his book, Estrogen Matters, many of the study's co-investigators didn't even have an opportunity to fully review or debate the final manuscript before it had already been sent to print. This concern was echoed years later by journalist Tara Parker Pope in her Wall Street Journal article, How NIH Misread the Hormone Study in 2002. It questioned not just the interpretation of the data, but the way the results were communicated to doctors and the public. In other words, the message was already out in the world before the scientific conversation had really happened. I'm not saying that this data was fabricated, and it doesn't necessarily mean anyone intended to commit fraud, but it does mean that the normal rhythm of science was completely bypassed. So normally when a major study uncovers potentially practice-changing breakthrough results, there's a very deliberate sequence. The data are finalized, investigators debate on what the findings actually mean, the manuscript is reviewed by all the authors, then it goes through peer review where independent experts that aren't involved challenge the conclusions before anybody sees the headline. Only after the paper is published, usually with an embargo, meaning doctors see the data before patients see the headlines, that's when clinicians and journalists can get time to digest the data before the public messaging begins. That process is there to protect the nuance. With the WHI, though, that sequence was flipped. The press conference came first, the headlines came next, the paper followed after the story had already been written. Once that happened, the scientific debate didn't disappear, it just didn't matter. Under normal circumstances, findings like this move from internal review to publication over months, often 6 months, maybe a year, allowing time for debate and peer review and context. But with the WHI, the entire process was days or weeks. When it gets compressed into headline speed, that nuance never really has a chance. And once that press conference happened, the story was essentially locked in. Because once something becomes a headline, it stops being a question and starts being a conclusion that's quoted over and over again. Well, let's talk about the number that everyone remembers from the WHI, a 26% increase in breast cancer risk. Well, that sounds kind of terrifying. And that's because that 26% is a relative risk. Relative risk is great for grabbing attention, but it's not that great for clinical decision making. The absolute risk difference, the part that actually matters when you're counseling patients, was about 1 additional breast cancer case per 1,000 women per year. That context was almost entirely missing from the public message around the WHI. And once fear enters the conversation, nuance doesn't really stand a chance. The investigators concluded that for this specific hormone combination, conjugated equine estrogens plus medroxyprogesterone, the overall health risks outweighed the benefits. They also concluded something that gets mentioned far less often. Overall mortality was not increased. Women in the hormone group did not die at higher rates overall. They did have a slightly higher risk of breast cancer diagnosis. Based on how the trial was designed, the authors concluded that estrogen plus progestin should not be started or continued solely to prevent coronary heart disease. Well, most of the results were reported as relative risks. So things like about a 30% relative increase in coronary events, around a 40% increase in stroke, about a doubling of pulmonary embolism risk. Well, those numbers sound really dramatic, and in relative terms, well, they're scary. But at the same time, there were substantially fewer hip fractures, fewer colorectal cancers, and again, no increase in total mortality. When you sort of translate all this into absolute risk, the picture looks a little bit different. When you look at per 10,000 women per year, the differences worked out to be roughly 7 more heart events, 8 more strokes, 8 more blood clots, 8 more breast cancers. On the benefit side, about 6 fewer colorectal cancers and 6 fewer hip fractures. So when you tally everything together, combining it into the studies, it's called a global index. The net difference came out to 19 additional events per 10,000 women per year. So that's a 1.9% absolute increase in all adverse events. Well, we might disagree about how to interpret that, but the key issue is that those were pretty small absolute differences spread across many different outcomes. And yet the message that most clinicians and patients heard was simple and absolute. Hormones are dangerous. End of story. So that jump from nuanced data to this blanket conclusion is where the real problem begins. Avram Blooming and others have pointed out that the WHI, it seemed to be analyzed and reanalyzed in ways that consistently emphasize the harm of hormones. Composite endpoints, repeated looks at the same outcomes, subgroup slicing that reinforces risk. And when later analyses showed neutral or even favorable findings, especially in different populations, those results tended to maybe get far less attention. They definitely didn't get a big press release or a press conference. And here's where it's important to see some balance. When investigators went back and looked more carefully at the age of the participants, timing, absolute risk, a different picture begins to emerge, particularly in younger women closer to the onset of menopause. When long-term follow-up data were examined, all-cause mortality trends looked more favorable in younger women. In fact, women aged 50 to 59 who took estrogen alone showed a significant reduction in overall mortality over extended follow-up, while combination therapy in younger women appeared largely neutral. Perhaps most importantly, extended follow-up made one thing very clear. Absolute risks for most adverse outcomes were substantially lower in younger women. Even when relative risks looked similar, the real-world impact was very different. Those findings don't erase risk, but they did change the benefit-risk conversation in meaningful ways. This is where journalist Tara Parker Pope made an important observation. She noted that the WHI wasn't just published, it was interpreted for the public. Once that interpretation took hold, it didn't really matter what came later. Science kept evolving, but the narrative, the Women's Health Initiative story, didn't evolve. It was set in stone. The real legacy of the Women's Health Initiative isn't just the data, it's the story. And that narrative stoked the fear of hormones that oddly has persisted for decades. It also dictated the training culture that sort of developed around that fear and the hesitation that still shows up in exam rooms today. We didn't choose that story, we inherited it from our colleagues 20 years ago. And if we want to practice hormone therapy confidently and responsibly, we need to understand not just the numbers, but the way those numbers were turned into a message, a narrative. Because the WHI didn't just study hormones, it showed us how easily nuance can disappear once fear takes that microphone. So let's not let fear drop the mic and walk away. The Women's Health Initiative and the scary story that grew up around it isn't the last word on hormones and menopause. In fact, there have been several important studies published since 2002 that have added clarity, nuance, and perspective to what we know about hormone replacement therapy. One of the most important of those studies is the subject of my next video, so we'll see you there.